Okay, well, I know we're probably going to have a few people still joining us, but let me introduce myself. I'm Dr. Leslie Schover. I'm the founder of Will to Love, and I'm a psychologist, and this is our first webinar. So I have just a few introductory slides that I want to share with you. Oh dear. Okay, so of course the name of our webinar is Bring It Up, talking about sexuality and cancer care. Now for our agenda, we're going to have two speakers tonight. Our first is Dr. Jennifer Barsky Reese, who is on the faculty of Fox Chase Cancer Center in Philadelphia, and her talk is called Talking About Sexual Health and Cancer, Research and Tips for Success. Our second speaker, Erin Sullivan Wagner, is a cancer survivor herself and patient advocate and founder of aftercancer.co. She's going to be telling some of her own story, as well as talking about her work helping oncology professionals to bring up and manage sexual issues in cancer care. I will be your moderator, especially during the question and answers. And I just want to bring your attention to two websites I hope you'll visit. One, bringitupsexandcancer.com is the website for our public health campaign, Bring It Up, Sex, Cancer, and Fertility. And you can find 3-step action plans to help patients and healthcare professionals deal with these issues more comfortably. And I hope everyone may have already visited Will to Love, and if not, that you will visit us soon. So with that, I'm going to stop sharing my screen and we will get Dr. Reese up to give her talk. So let's unmute. Oh, yeah, that's Erin. I'm sorry. Unmute, okay. Stop my video.
Okay, it looks like I'm unmuted.
Yes.
Okay, great. So can you hear me okay?
Yes.
Okay, perfect. Well, I want to thank Leslie for inviting me to be a part of this webinar. I was very excited to be able to contribute to the efforts that Dr. Schover has been working on with regard to Will to Love, and anything I can do to help, and as well as being involved with this process, I'm happy to do so. So thank you all for attending. As Leslie mentioned, I'm in the Cancer Prevention and Control Program at Fox Chase Cancer Center. And I'll be talking with you tonight about some research and trying to lead the way into some tips for success with regard to increasing communication about sexual health and cancer. So as many of you know, and I took a look at some of the names of some attendees. It looks like many of you are very aware that that sexual problems are a big issue for a lot of patients with cancer, and around half of cancer patients have sexual problems. Of course, that depends on the cancer site, but these are just some of the types of problems that patients experience: loss of desire and pleasure, erection problems, vaginal dryness and pain, trouble reaching orgasms and changes in orgasm, and body image changes. Many couples stop having sex or lose intimacy altogether. And for people who are not partnered, cancer can create difficulties for dating and body image concerns in particular. Fertility concerns are common and troublesome. And we know that sexual problems, unlike other common issues that result from cancer treatments like pain, rarely go away without treatment. They're very persistent. And yet fewer than 20% actually see a health professional about these issues. So a few years ago, I was involved with a large study that was a part of the PROMISE scale validation effort. And as a part of this study, we asked a few questions of the the large sample of cancer patients. And one of the questions was, how important is it to you that your doctor or nurse discusses how your cancer or cancer treatments may affect your sex life? And the fact that I wanted to bring out here is that the majority of patients, and this is across a range of different cancer types, endorsed that statement. They felt that it was at least somewhat important that, that their doctor or nurse discuss cancer or cancer treatment's effects on their sex life. Another important data point that came from that project was this item. Have you ever received information from an oncology doctor or nurse about how cancer or cancer treatments may affect your sex life? And overall, the percentage who reported that yes to this was 45%. But when you break it down by cancer type, you can tell that this was heavily swayed by the large percentage of prostate cancer patients who were reporting that they had received information about effects of their cancer treatments on their sex life, whereas for other cancer types, even that are recognized to lead to sexual problems in terms of their treatments, the percentages who had received cancer, information were pretty low. So a number of research studies have, over the past number of years, suggested that there are significant barriers to patient-provider communication about sexual health that need to be addressed. Oncology clinics tend to be overburdened. It's difficult to get reimbursed for adding sexual counseling when the visit is already scheduled. Payers put a low priority on reproductive health problems, and there's poor insurance coverage. Few clinicians have adequate training. Patients and providers both report feeling uncomfortable discussing sex. And few mental health professionals are cross-trained in cancer and sex therapy. And then finally, especially in rural areas, there's often a lack of adequate referral sources. There are other barriers I'll be talking about later as well. I do want to talk a little bit about some data that we obtained recently from a systematic review. And the idea here was to take a really a more detailed look at the prevalence or how common patient-provider communication about sexual concerns and sexual health is in cancer, because it's kind of assumed, and it's sort of been common knowledge that this is an issue that's under discussed. And so we were really interested in taking a look at how common is it actually, and then what is being discussed, if we can figure that out. So we looked at 29 studies that were conducted across 10 countries in the systematic review. And there were different prevalence rates of communication depending on the type of communication that was assessed. And these were all assessed using very different measures, I should mention too, from a quality standpoint. So when it comes to whether or not patients reported that their providers had discussed potential treatment effects on sexual function, this tended to be where providers were doing the best and where patients were getting the most information. So if they were going to hear about sexual issues at all in the course of their cancer care, it tended to be up front in the informed consent discussions or in the discussions about potential sexual side effects. So overall, around half of the patients reported that they had had a discussion to this effect. However, when you break it down by gender, more than twice as many men reported that they had received this kind of information as compared to women. When you look at actually assessing sexual concerns, so whether or not providers assessed patients' sexual concern, there weren't as many studies, first of all, that actually looked at this. But the few that did, again, found kind of some gender disparities. So asking men about erectile dysfunction, 52% of the nurses in one particular study said that they had asked men about this issue, whereas only 1/3 of them said that they had asked about vaginal dryness. So, so as you can tell, there's starting to definitely be a theme there. And then the final type of communication I wanted to talk about is addressing sexual concerns. And this kind of coming later down the line in terms of the course of a discussion is also much less prevalent. So 22%, and this is patient reported, reported that they had any sexual concerns addressed. And this would be something like being offered suggestions, or advice or things like that. And there were particular populations that this was assessed in. But the interesting thing here is that the gender disparity starts to converge when it comes to actually dealing with sexual concerns. Men and women reported fairly similar levels of having that kind of communication take place. So I also looked at the factors across these various studies in the systematic review that had been shown statistically to be associated with greater rates of communication. And the ones that came out, and that I'm showing you here, are the ones that had at least 2 studies with supporting data suggesting that they were associated with greater likelihood of, or greater prevalence of communication. So male patient gender, which isn't surprising based on the data that I've already showed you, whether the cancer was affecting the genitals in particular, this was associated with greater communication. And then if the provider had more years of clinician experience. So I believe that there were about 2 studies that found this was supportive of this, and then 1 study that found no significant difference. So even there, it's a little bit mixed, but there is some signal there that perhaps having a greater number of years in the business makes one more comfortable bringing this issue up. So taking all of this data and as a part of a project that I've been working on for a couple of years with the American Cancer Society funding, I have been trying to think about what we can do to increase and enhance communication about sexual health in cancer. And I've specifically been focusing on breast cancer. As you saw in some of the earlier slides, only about 1/3 of breast cancer patients had reported receiving any information about sexual health in the context of their cancer care, whereas at least half, if not more, in some studies, breast cancer patients report this to be a concern. So it seemed like it's a gap, particularly in this population, so I wanted to take a look at that. So I conducted a qualitative study in both patients and providers. All of the 28 patients had reported at least some sexual concerns, and the 11 providers who were interviewed, it was a mix of oncologists and nurse practitioners. And the goal here was to develop an educational program, actually 2 interventions, 1 for providers and 1 for patients. And so, when you tease out all of the qualitative data, one of the really interesting things that came from this was the idea that patient communication and provider communication each drives the other. This is sort of a glass half empty, half full kind of a thing, because I think you can look at it like in a positive way, where when patients raise this issue, it kind of drives the provider to have to discuss it, to have to deal with it. And then the other way, when providers, bring it up, it gives permission to the patient to talk about it. However, there's also a little bit of that question of, is it passing the buck, to the extent that, patients, kind of say, well, my provider should bring it up. Provider says, well, I'm not going to bring it up unless the patient does. So it's a little bit of kind of a glass half empty, half full kind of a situation. But regardless of that, I think it does suggest that there are going to need to be interventions that can intervene on both sides here. And so it's important to both activate patients to raise the issue, and then also to train providers to at least be able to give some information and ask about sex, and if that's a question or concern. So I certainly think that there's room for improvement on both ends. There were some other key findings. There were other communication barriers. Most of the ones we found were negative beliefs about discussing sex, emotional discomfort, and knowledge or skills gaps. And then, of course, the one that we hear all the time is lack of time and time constraints. And I do think that that's a realistic issue. A positive patient-provider relationship was key. So trust and respect and confidentiality was important. Patients' informational needs did go beyond sexual performance. So is sex safe? Can I engage in it? What about changes to my breasts? Nobody talked about that with me. However, patients didn't seem to expect their doctors or their nurses to be experts. They basically expected and kind of hoped for this open and direct communication, and at least having their provider kind of discuss it with them or raise the issue, and then let them kind of figure out what they wanted to do with the information. So, to go to some of Leslie's bring it up, kind of steps. And what I've tried to do here is to kind of look at some of the work that Leslie's put into her, bring it up kind of tool, and kind of think about the work that I've been doing as well and try to integrate them a little bit because there are a lot of similarities. And certainly I think one of the key things we really want to do is just start bringing it up. So with regard to the patients, what we can encourage them to do: step one, ask for time to tackle a special question. Let the clinician know you want some extra time. Think ahead about whether there are personal differences that you should discuss, such as culture or any gender-based concerns. Choose your question. And I've really come to think through the work that I've been doing now in actually audio recording breast cancer patients' clinic encounters, that it's tough to ask questions, and that we really can help patients by giving them permission to ask questions and by activating them around that. So asking a question helps your clinician help you, and making that clear. It's not a burden on the clinician. So thinking about where you are in your cancer journey as a patient, if you're just starting your cancer journey, perhaps asking a question about how the treatment will affect you, or whether sexual activity is safe to engage in while you're on chemotherapy, for example, or another treatment. Or you could let the provider know about a long-standing sexual issue that you're worried could get worse. So here are some examples, and I'll probably start going through these sort of quickly because I'm seeing it's 9:19 already. How likely is it that this surgery will lead to sexual problems? Is it safe for me? Step two, so again, choosing your question. If you're already having a sexual problem, you can focus your question to be especially effective. Give enough information so that it'll be helpful. And here's just an example. Since my cancer treatment, I've been having a problem with one of these various problems. What kind of help is available? Here's another one for someone who has a more difficult or recalcitrant problem. I've been using this lubricants or medications. It hasn't been helpful. It's starting to affect my relationship. Do you know anyone that could help me with this? And the idea there is that kind of giving your provider a sense that this is important to you could be helpful, that this is relatively severe. With regard to fertility, if this is a high priority, let your clinician know before you start cancer treatment or as soon as possible. My ability to have children is really important to me. What are my options? During or after cancer treatment, you also may be thinking about parenthood in the future, and your question may be slightly different. How can I find out if I am still fertile, and what options do I have for becoming a parent? So again, I'm kind of going through these a little bit quickly, but I want to make sure that I am able to get through everything and not eat into Erin's time. Step three, don't leave without a plan. And this is where that activation piece really comes in. It's like, how many questions do you need to ask in order to get your answer that you really need? So your oncology team may have limited knowledge on how to help you. And so, you may need to persist and in order to get the information that you need. So does this hospital or other system have a clinic that treats this problem? Can you refer me? Do you know a specialist who can help me? Do you know any books or websites, for example? And then for providers, just fairly quickly, I'll be condensing these tips. But number one, bring up sex and fertility at each visit. This may be a little bit easier than it sounds. And what I had found from talking to providers is that it's important to find a way to raise sexual health that feels natural. Many providers said that they have a different way that feels comfortable for them. And so I don't know that there's any kind of prescriptive way that is appropriate for everybody. So one way to do it would be to have a normalizing statement. A lot of patients who've had this treatment say they have changes in their sex lives or trouble with sexual function. Do you have any questions or concerns, about this or about your sexual health? And then here's one that I put in, and I put this in because one thing we heard from many breast cancer patients was that no one had told them whether it was actually safe for them to continue engaging in sex. And I was really struck by that because that's an issue that's not really captured in the sexual function scales. And so I think it could be easy to miss even if you're assessing for it using an actual sexual function measure. And so, you know, I know you may not be thinking about this right now, but I wanted to let you know that sex or sexual activity is generally safe while you're on chemo, as long as you feel well enough for it. Some providers recommend waiting a couple of days after your treatment in case there's any drug in your system. You still need to use a barrier method to ensure you don't get pregnant. But this is, you know, another kind of idea to give you. And then step 2, train and support a clinic sex and fertility expert. So I think this is a part of the idea that it's definitely recognized that clinicians are pressed for time. And that's absolutely 100% true. And so finding someone who could potentially have the time and the support to be able to do this would be ideal. So find an expert you can refer to for further assessment, potentially counseling, and then create a specialist network. So learn about who is available to fill a multidisciplinary team depending on your clinic population. You may need to look both within and outside of your institution. And so this is really just a very kind of quick overview. I think there's no, you know, I think it's ultimately going to have to be a multi-pronged effort with efforts on both the patient side, the provider side, and I think ultimately systemically as well, to address those systemic barriers as well. So whether you're a patient or survivor or a cancer clinician, don't use this guy as your role model. And thank you for your time.
Okay, Jenny, can you stop sharing your screen?
Yep, got it.
Okay, all right. Well, that was a wonderful talk, and I know we do have a couple of questions that we will be addressing at the end. But what I'd like to do now is go ahead and have Erin, our second speaker, do her talk. So let me unmute Erin.
Hello, everybody. Hello, I'm Erin. Tonight, I just have a couple of slides. So you're going to see my face actually telling my story. And actually tonight, I'm going to read my story. I wanted to make sure that I didn't miss a detail. So I wrote it all down. So hopefully it's still interesting. Sometimes I think storytelling is better when it's impromptu and not read, but I'll try to make it as interesting as possible. So the 2 slides I have will show at the end, and it will have some contact information. So my story begins, like every survivor's story, with a diagnosis. My diagnosis was anal cancer in January 2008 after a colonoscopy. I was 48, a few months before my 49th birthday, when I noticed a little blood on the toilet tissue after a bowel movement. I noticed it on 3 to 4 different occasions over a 3-week period. And the last time I noticed it, there was blood dripping from me. I didn't have a history of hemorrhoids, and after seeing the blood, I got an appointment with my gynecologist right away. Those who have heard those words, "I'm sorry you have cancer," know how mind-numbing the diagnosis is. In my case, there was some confusion from my medical team about the kind of cancer I had. So they settled on, eventually, anal cancer, which only added to my confusion. I had never heard of it. I was confused even more when the colorectal surgeon, who was also part of the team diagnosing the cancer type, said to me, "You know, I used to only see this in gay men, and now I see it in women your age." She didn't offer an explanation, and I didn't ask. Like so many others with a new diagnosis, I was frozen with fear. Before my diagnosis, I felt great. I was extremely active, happily married, raising children ages 12 to 17 years. One day I was living a regular life, and the next day I was part of a world full of medical terms, blood tests, serious conversations about risk and survival rates. And I was scared, confused how my body could have betrayed me without my knowledge, and knew for certain I wasn't in control. My cancer therapy regimen was 5 weeks of radiation, 25 rounds, and chemotherapy, 5-FU and mitomycin during the first and last week of radiation. I had multiple visits with various team members in medical and radiation oncology, was given a packet of information on each therapy, and a list of expected side effects. With the chemo team, I was told to review the list and ask if I had any questions. I had seen the word sexual dysfunction listed as a side effect in previous literature, and though I was curious about what it meant to be a female with anal cancer, I didn't ask. When I met with my radiation team, they also had a list of side effects that included sexual dysfunction. But without me prompting, I was told it wouldn't be a problem for me because I was young, healthy, and sexually active. On a separate visit, I was told it wouldn't be a problem because I wasn't having internal radiation rods. My radiation would be external. On that same list of side effects, right below sexual dysfunction was listed death. And I think that also stifled me from asking anything about sex. Death seems to have a way of putting everything else in perspective, doesn't it? Like most people diagnosed with cancer, I wasn't concerned about my sexual health at that point. I really was only concerned about curing the cancer. All of these discussions about side effects were within a few days of the diagnosis, and at that point, I really still had this mind-numbing fear, and it was difficult to care or concentrate on anything other than just keeping myself as strong as possible in preparation for the upcoming treatment. My therapy lasted 5 weeks, from February 11th to March 14th. I got through it without missing a day. But because of the dehydration and extremely low blood counts, I was hospitalized for a week following my last day of treatment. At that point, I was weak and very sick. But my body bounced back quickly. Every day I wasn't receiving radiation, my skin began to heal. At my follow-up appointment 2 months later, so that would have been late May, we were told that my body had healed well enough and we could resume sexual activity, specifically intercourse. The only instructions we were given were to go slow and to use some type of vegetable oil for lubrication. We were both nervous for that first attempt, especially me. It had been over 4 months since the diagnosis and 4 months since we'd had any sexual activity. My genital area felt far from completely healed though. The area was tender and my skin was really sensitive to touch. And my whole body felt different. I was weak with very little energy. Our first attempt was over really before it started. I thought they must have been mistaken about how healed my skin was. It felt like he was pressing up against, trying to penetrate a wall that was stopping him. I assumed he was inside of me, but I couldn't tell. It didn't feel like there was enough lubrication, or actually it didn't feel like there was any at all. From his perspective, he didn't think he had penetrated my vagina at all and didn't understand why I was immediately in so much pain. My body immediately reacted like you do when you're in pain, and I couldn't muffle the sounds I made from the pain, and I moved my hands between us to act as a barrier and to stop anything further. We both hoped that I just needed a little more time to heal. I wished I could have been able to see, like with a camera, what was happening during our intercourse attempt, so I could better explain it to my husband and my doctors as to why I was feeling so much pain. Every attempt to have intercourse was met with the same severe, urgent pain, no matter how slow, how lubricated, or how relaxed I was. The pain was a 10 on a scale from 1 to 10. It felt like sandpaper being rubbed against an open sore, or it felt also like my skin was just being stretched beyond its limits. Each attempt ended with a little blood and silent tears. In those first months and in the first year, we talked about it, trying to better understand what each of us thought about what was happening and how we felt. We were hoping then that talking about it would help, and talking about it came easy. I felt like we were equally concerned and disappointed about the progress I was making in regards to healing and getting back to normal. At my follow-up appointment, I told my medical oncologist. They hadn't heard of sexual issues from other patients, so eventually just referred me to my gynecologist, and she began to investigate the possible issues that were causing the pain. So in September that year, I began various therapies that continued on and off for several years, hoping to resolve the issue. After examining me for the first time, she determined that there was a buildup of scar tissue in the vaginal canal caused by the radiation and no estrogen in my body. She believed that that must be causing the pain during intercourse. You know, when I speak of this, when I describe the activity, I notice I never say lovemaking. I always say intercourse. What was happening during these episodes wouldn't have been considered by anyone's account lovemaking. It wasn't natural. It didn't physically feel good. I was scared from beginning to end, and my reactions didn't exactly turn him on either. I had minor surgery to remove the scar tissue, but that's a short-term solution. Scar tissue continues to develop unless that area is kept open. We were encouraged to have intercourse as often as possible to keep the vaginal canal open. I was also given estrogen moisturizer suppositories and an estrogen cream because the therapy put me into menopause and my estrogen levels were extremely low. Using estrogen would hopefully keep the tissue healthy and reduce the likelihood of scar tissue buildup. During that same time, I was given dilator tools, graduated in size, to insert inside for those times when we didn't have intercourse. So for me, that meant always. They were intended to help stretch the vaginal opening and the inside area, and like a penis, to keep the scar tissue from building up. There were 5 sizes of dilator tools. I started with the smallest and worked my way up to the 3rd largest size. The goal was to stretch the opening and the insides to a size larger than a penis, so intercourse could be possible and eventually comfortable. Unable to work through the pain, though, to stretch the skin far enough on my own, I was eventually prescribed a nerve-deadening compound to be applied at the opening of the vagina and also applied in a circular fashion directly inside the opening. While lying down, I used a dilator tool to stretch the area for 10 to 15 minutes while a nerve-deadening cream took effect. And then I attempted to insert a larger dilator tool, the 2nd largest in size. My skin always ripped, I always bled, and had to remind myself to breathe through the pain. This was my regimen 2 to 3 times per week. I was eventually referred to a rehabilitation therapist to knead the muscles of the vaginal walls 1 to 2 times a month on and off for years. This therapy was successful in making room for a penis inside the vagina, if only I could penetrate the opening. When I no longer continued to make progress, I was prescribed Xanax as an additional strategy to help me relax 45 minutes before intercourse. So guess what happened? I fell asleep. Every time I took Xanax, I fell asleep. So in the end, none of the therapies were successful because the scar tissue at the opening of the vagina had been left to grow, to build up, and cause my skin to lose elasticity and any flexibility that normal, healthy, non-radiated skin would have. From the beginning of my cancer treatment in February to being treated with those various therapies using dilator tools and estrogen moisturizers, 9 months had passed. We had been given no expectations to prepare for any of it. I couldn't have imagined how difficult this would be on my relationship with my husband. He had been such a wonderful support and caregiver during my cancer treatment. We started off devastated together about the diagnosis and then elated when the cancer therapy was successful. We were both excited about getting back to our old lives that included lovemaking. It had always been an important part of our relationship. We were both apprehensive at first, and we were both fearful of hurting me, and both equally disappointed and worried about what went wrong when intercourse didn't work after 4 months of trying. And we both stayed hopeful. But somewhere during that time of our lives, after the first few years, I think, we failed to stay on the same page. I could tell how disappointed he was, and I tried to convey how sorry I was. I felt responsible for our inability to enjoy sex and wanted to fix it. I knew he missed it like crazy, and I missed him. I needed to talk about it, and when we did, I did all the talking. I don't think either of us felt better about those conversations. He didn't understand why my body would act different than other patients who had gone through this treatment previously. The doctors didn't expect this and obviously weren't acting like they knew how to fix it. We assumed I was different from others. At one point, he questioned me and suggested that possibly my pain wasn't real. That possibly I was just remembering that initial painful experience and that it had left me traumatized, causing me to tense my muscles, which brought upon the muscle spasms and pain. Of course, I knew this was a ridiculous assumption. The pain was so real. I began to feel angry about it all. Why hadn't my medical team known this would happen? Why was I different? When our conversation stopped, our connection to each other wasn't as strong. I watched his disappointment, now frustration, turn to silence. He said he didn't miss our normal lovemaking, he missed me. He thought I had also changed, and he was right. I didn't feel the same passion I once had. I wasn't aroused easily. I didn't have natural lubrication. It was a long time before I felt 100% in terms of energy. I needed different things from him than I had needed in the past. I wanted intimacy also, but craved more emotional than physical intimacy, and didn't understand why it seemed like it was intercourse or nothing. We should have been talking regularly about it, but I knew he dreaded the conversation. It never seemed that he had much time for it. It also never felt like anything ever got resolved when we talked. We should have been in counseling. I was doing everything I could to fix it, to get our life back, to find a way to connect again. I knew we weren't the same without intercourse in our lives, and we weren't admitting it. I just didn't know how to fix it. I had to convince him to keep trying to have intercourse because we needed to test the specific therapy I was in at the time. I explained that it didn't do any good for us to spend the time or the money or for me to go through the pain of the therapy if we weren't going to test if it was successful. At first, asking him to have sex with me was kind of like a flirtatious game. But with every failed attempt at intercourse, it became harder to convince him to continue to try. He would say, "I can't do this with the look on your face, Erin." Or, "Your face doesn't hide the pain you're in, and neither does the rest of your body, and there's nothing arousing about this." Or, "I don't want to be the source of your pain anymore." It was no longer something we were working toward together. We weren't on the same page. I was begging him to have sex with me, and we were both dreading it. I had to convince myself to even suggest it. When I considered my commitment, though, to the relationship, I felt like I needed to keep working on every possible treatment out there. He said it didn't really matter to him, and I knew he was lying. It mattered because we hadn't adjusted, and we hadn't found a new way to find intimacy with each other. Intercourse had been a form of communication for us, and that communication connection was gone. People often say, or they think and they don't say, that intercourse isn't everything. There should have been other ways to be intimate. Why not just substitute other activities of lovemaking? And though that should make sense, it isn't easy to change that sexual script developed over years as one might think it would be. My libido was low, along with my estrogen levels and my energy. Fatigue affected how I felt about sex, how I felt about him, and how I felt about us. My skin had changed, the sensitivity was different. His touch that had once motivated passion, lubrication, and arousal in me now felt too hard, not pleasing, and left my radiated skin feeling irritated. I didn't respond the same way to his touch, nor he to mine. And it all felt like work, unpleasant work we weren't even good at. It was impossible not to let our issues related to intimacy not impact the rest of our relationship. We believed it was a short-term problem, and we weren't addressing it with the urgency it deserved. We let ourselves drift apart from one another. Communication on this topic and every other topic happened a little less often. I didn't recognize the couple we had become. All of the disappointment in each other and in ourselves added to how disconnected we were. We grew apart and finally separated 1 year ago. In the few years leading up to the separation, I could see the distance between us emotionally becoming greater. I gradually accepted the distance and the part I played in it. Some things I couldn't control and others I could, but I let happen to us anyway. Sexual health issues weren't the only issues in the relationship. It seemed impossible to work through any of it. We didn't deal with it when we should have, and it fostered an environment that allowed other issues to go unresolved. We haven't divorced, and in fact, we are spending some quality time together these days. We don't have the same demands of each other or lofty expectations, and there's no pressure to make anything work. We've started over, giving ourselves an opportunity to make something new of this relationship or agree to walk away. We're still not exactly on the same page, but definitely part of the same chapter in life. 7 years ago, I became a certified life coach and listened to other patients' stories, working with them to find intimacy again after cancer treatment. I began After Cancer, Solutions for Sexual Health, as a resource for both patients and healthcare providers. And through my coaching work, my advocacy, and my volunteering, I've chosen to be a voice for patients who need sexual health care addressed in the oncology setting, where the impact of the treatment side effects begin, so that expectations can be set and referrals made when needed. My story wasn't unique. Stories like mine are common because addressing sexual health isn't part of our standard of care yet. My story could have been very different. If sexual health had been addressed and expectations set by my medical team during my active cancer treatment, I would have been able to prepare myself and my husband, and our conversations wouldn't have had to take place after disappointment, confusion, and frustration. We could have considered couples counseling as a normal event that is commonly needed. We could have considered simple strategies of how to communicate with each other about sex and our individual needs that had changed. If I had been referred to a physical therapist right away, I could have received treatment before the damage was permanent. My inability to have intercourse could have been short-term. My current healthcare provider has made that clear. Following my personal experience, my life coaching work with patients led me to collaborating with the medical community on developing training on addressing sexual health with patients. I began to work with gynecologists and reconstructive urologists on a presentation to raise awareness to the oncology community. A presentation from the perspective of a former patient and 2 physicians who deal with the issues in cancer survivors for months and years after treatment, issues that impact the quality of their lives. Because of the interest from oncology providers in our project, I applied for grant funding to develop training materials and an educational program to address these issues with their patients, to normalize the conversation, to set appropriate expectations, and to timely refer patients to other specialists when needed, mental health specialists, physical therapists, couples counselors, or couples coaching to address those communication issues that develop after cancer experiences. The project is getting a lot of attention from healthcare providers in Iowa, and we plan to continue it outside Iowa as well. The project is called All of Me, Prioritizing Sexual Health in Oncology, and the website is allofmeiowa.org. The site will house resources for both patients and providers. Healthcare providers can get CEU and CME credit for attending the on-site training programs. These workshops include role-play exercises in oncology settings with simulated patients and up to 6 learners practicing, initiating the conversation, and addressing sexual health with patients on a follow-up basis during or after their active treatment. We use the participants' current communications roadmap to identify opportunities to bring it up with patients. Also, we review their current referral algorithm to get comfortable with when and to whom to refer the patients to. I'll show the slides here to give you the contact information for your reference. For patient resources and coaching services, go to www.aftercancer.co or email me at Erin@aftercancer.co. If you're a healthcare provider and want resources or information on the grant project, you can get that at either website, at aftercancer.co or at allofmeiowa.org. Right below that is my phone number as well. In conclusion, if you have patients that need coaching, contact me. I would love to hear their story and help if I can. Visit my website for further information and resources. I appreciate the opportunity to tell you my story. I'm just one of millions just like that. Thank you. If you have any questions, just leave your questions in the chat box.
Okay. Erin, if you could stop sharing your screen, I'm
Okay.
going to have all three of us up here so that we can answer the questions. So Jenny, if you could start your video too, you're also unmuted.
Okay, great.
So we have several questions that came in our question and answer box. One, Jenny, is for you, and it says, for Dr. Barsky, please elaborate from your study, what were some of those negative beliefs about sex?
Right. So there are many negative beliefs about discussing sex or about communication about sex that, oh, am I really soft? I turned my volume down, so let me turn it up a little bit.
I think you're okay.
All right, well, I turned it up just to be on the safe side. Patients and providers both talked about and discussed a range of negative beliefs, you know, from the patient side, not wanting to burden their providers, not thinking their provider would respond well, thinking their provider, you know, would be too busy. We heard a lot of, you know, my provider's looking at the computer screen, or, you know, perhaps they've had another negative experience and they didn't, you know, want to bring it up. So I think a lot of, you know, a lot of negative beliefs. On the provider side, we heard a lot of beliefs about, you know, well, you know, if it's important to my patient, they'll bring it up. So I think that that's a belief. I think that's a faulty belief. I mean,
We've
the other thing,
a bunch of studies, whether it was fertility or sex, you know, the provider always says, well, if it's important, they'll bring it up. But as you well know, the literature suggests that maybe 10% of the time, people who have really big concerns bring it up because it takes a lot of courage and assertiveness.
right. And the other thing that I thought, so I thought a lot about this issue of time constraints, and I feel that I feel there are absolutely realistic time constraints, but on the other hand, I do feel that it's a slightly faulty belief that, you know, it takes a lot of time to discuss this issue. And so that's where that belief comes in on, you know, well, this is going to take up too much time. I don't have anywhere near the kind of time that this is going to take, where when you compare it to other things like discussing patient distress or discussing pain, you know, well, those things may be complex. Those things may take some time to discuss, but that doesn't mean that, you know, they're not going to be discussed, and they may not take as long as you actually think that they would. So, yeah.
In fact, Jenny, one of the findings that you relayed to me that I thought was fascinating is, you know, one of the things we always say to oncologists is, well, ask an open-ended question that you can't answer with a yes or no. But when you were talking to oncologists, can you say a little bit about what their reaction was to that advice?
Right. I mean, I think that they were wary of of that advice. You know, we heard a lot of people say, well, you know, it's easier for me to ask about, let's say, vaginal dryness and kind of include it in, you know, a review of systems, and it often gets asked as a yes or no. And, you know, part of it is, well, you know, is it better to ask a yes/no question as opposed to nothing? And I definitely think that's true. I mean, ideally, it would be an open-ended question, but I had kind of, after doing those provider interviews, I modified my thinking a lot, kind of with regard to being a real, you know, being really stringent on the idea that, well, we have to really push providers to ask open-ended questions, because I kept being more and more convinced that if we can't come up with tools and advice and guidance that are actually helpful and that are actually going to be realistic, you know, realistically used by providers in their busy practice, then I don't really think it's going to ultimately solve the problem.
I totally agree. I think we need to get providers to ask a quick question, but then have something easy to do so that the patient
Right.
can get their needs met. I have
Right.
one more question for you, Jenny, and it's from a prostate cancer survivor, and he is asking, on the histogram where you showed the percent of breast, lung, and prostate patients, etc., there was an 80% bar for prostate cancer patients, which of course skewed the results. And he was wondering, what was the source of data for that histogram? Was it from a certain part of the country, like, for example, the Northeast? And was it from a particular clinic or hospital or more academic centers? And said you did a great job on the talk.
Well, thank you. Yeah, so that study was, that was from a validation study. So it was from a large scale study that I believe used knowledge panel or kind of one of these like knowledge networks. I can't remember exactly what the title is, but it used one of these sort of large scale recruiting kind of networks. And I believe that the goal is to have the sample be more normative, like more generalizable in nature. So the sample was not collected from any one particular, cancer center or, anything like that. It wasn't kind of just a survey that was sent out, to like all, patients at MD Anderson or something like that. It was more widely dispersed.
I think what we see with prostate too is especially men who have radical prostatectomy are more likely to get some not only informed consent about the sexual side effects, but guidance on penile rehabilitation, the idea that you should periodically get erections to try to promote better recovery. So they do tend to have much higher rates of having gotten some information about sex than men or women with other cancer sites.
Mm-hmm. Right. And actually some data just came out, I think a couple of days ago. The Cancer Support Community released their 2017 registry report, and they have some data on communication about sexual health as well. And the rates were slightly lower there for prostate cancer than they were in, the study that I mentioned, but they were still higher, than they were for other cancer populations. And so, it's kind of a consistent thing, even though the prevalence rates will differ slightly depending on who's being asked, obviously.
Yeah. Hey, Erin, we had a question for you about whether you were given a vaginal dilator right after your radiation therapy.
So no, I wasn't. That's an interesting question though, because what I was told by one of the physicians, so a colorectal surgeon, the surgeon that said, wow, I only see this cancer in gay men and now I see it in women your age, also told me before I left that appointment that I would be given a dildo in radiation and it would make everything okay. And I know. So, I mean, my husband and I both heard that and thought, what am I supposed to do with this dildo? Is that like a parting gift? What would that be for? And I have anal cancer, so do they think I'm going to do something with the dildo? I just was so confused, and of course did not have a voice to be able to ask any of those questions about it. But what did happen was after I left that appointment, I ran into the gynecologic oncologist that also had examined me. And I asked him about the dildo I would get in radiation. And he said, oh my gosh, those are dilator tools. And that's what she should have said. And I'm sorry that didn't happen, but you won't need those because you're not having internal radiation rods. So I did ask my radiation oncologist just, by that, 4 weeks into it for fun, I said, I was told I was going to get a dildo. And so the radiation oncologist came in to speak to that and said that I wouldn't be and that I didn't need that. So a couple of times they had an opportunity to do that, but I started using dilator tools in September, late September, early October of that year.
Yeah. Well, for one thing, I wanted to say, Erin, to really thank you for your willingness and your openness to tell your story, which I think can help so many people. And I think you were just extraordinarily honest and frank about, what happened to you. And I really appreciate that. You were both wonderful. Jenny, your talk was wonderful. And Erin, your story was wonderful. And also, I know that the work that you've been doing since in your advocacy is also helping a lot of people. So I wanted to just make sure I made that comment. Yeah, I think, one of the things that seems is that, with anal cancer, I think a lot of the radiation oncologists so much underestimate the impact on the vagina because it's right in front of the anus, and you really treat one without impacting the other. And I think sometimes even if you give dilators right away and do your best, you still may have so much damage that it's very difficult to have penetrative sex. And it sounds like, I was wondering, it sounds like only in desperation after many months did you and your husband really consider whether lovemaking might include sex without penetration. And by then there was so much negative emotion that it was hard to even get aroused or have any kind of caressing without pain.
Yeah, so that's true. It was something that we felt like we had to work on. It was the problem child, so we kept working on it instead of maybe, focusing our efforts other ways just to find intimacy with each other. It was, we were both working on it like it was our job. And I, for all the reasons that I stated, I think I sensed that it would be important in our relationship, but I really just didn't know to what extent. And I don't know that my husband would entirely agree with me in terms of how important or unimportant it was to him. I could only judge from where I was in evaluating our connection to each other and how I felt in terms of being so responsible for it not being able to stay connected the same way. And I don't think I communicated so much through intercourse, but I think he did. I think I felt a lot of emotion from him when we had intercourse. Not just pleasure, but, I miss you, I love you, I'm thrilled for you. I mean, just, things that maybe some people say. I think maybe it was a communication path for him.
Well, I think that is a somewhat stereotypical but often true gender difference between men and women, that women often have an easier time communicating affection and love verbally and outside of sexual touching. And for a lot of men, the time they're most likely to, say I love you or give really loving touch is when they're initiating sex. And so when sex goes out the window, so does that. And we often see that when men have erection problems. I always call it when no erection equals no affection, because, and I think whether it's the man or the woman who feels like you're responsible because you can't have penis and vagina intercourse, which is so much the centerpiece in our culture, it causes just tremendous emotional turmoil.
Yeah, I think it did for us too. And I think it was a real cycle of sexual dysfunction. I think I needed emotional intimacy to even be interested in physical intimacy, and he needed just the opposite. And, very focused physical intimacy was intercourse. And now when I look back on it, I think, why was that the only path for us? I mean, of course it didn't have to be, but really, you can't see the forest through the trees when you're in the middle of it. I think hindsight has taught us both an awful lot.
Yeah. Jenny, I wondered, one of my experiences has been too that the communication can be even more difficult when there are big differences between the patient and the healthcare professional in terms of their age or their gender or their sexual orientation or even subcultures. I mean, working in tertiary referral centers, we see a lot of patients from, South America or the Middle East who have, very different gender role expectations. And I wondered if you had any thoughts about that.
I mean, I'll be honest with you, the research, I don't think is there. I mean, I don't think that there's really much research evidence to support that. I mean, one thing that we didn't see in the systematic review, we didn't really see that like a gender match made a difference. And just thinking about what people said in terms of like what the patients said, it was just all over the map. I mean, some women said, and remember, these were breast cancer survivors. So, some were saying, well, all of the, male clinicians that I had were the only ones that asked about sex. And then other ones said, well, I have a female doctor and she asks me every time. So I just don't see much of a signal there. Yeah. And I kind of feel like, if anything, it's one of those beliefs that like, it's like one of those cognitions or those beliefs that potentially does more harm than good. Because sure. What I did hear, though, interestingly, from providers, and I'm focusing here on gender because that's one of the only sort of things that I can really speak to. Like,
sure, that we do have any research on.
Exactly. But, providers did say some interesting things. And, for example, one thing I'm hearing when I'm, one thing that I should really talk about it because I haven't published any of these data. But,
this is just an anecdote. It's not.
It's just an anecdote. Yeah, I don't know this from my research at all. But some male providers have told me that they don't feel comfortable. They wouldn't feel comfortable asking a starting question using the same language as the way that one of the female clinicians, both oncologists, said that she did. And so the way that the woman asked breast cancer patients was much more sort of, any issues in your intimate life, or how's your intimacy, or any concerns in your intimacy. And the male oncologist, when he heard this, basically said to me, I wouldn't ask that because I would feel like the patient would think that I was potentially coming on to her. Like, those aren't words that I would feel comfortable using. And so keeping it much more clinical and much more technical was the way that he felt comfortable doing it. And so, so that's where the sort of review of systems, comes in. And that sort of influenced my thinking about, well, I don't really think there is one way that this has to be done, and that, it depends on what people feel comfortable doing. But I do think it's interesting certainly from a gender standpoint.
We have one more question. I'll read it. As a clinical psychologist who primarily works with adolescent cancer patients, my patients rarely report issues related to sexual dysfunction. But when they do, I'll often do a psychological and behavioral assessment, but we'll also refer them to gynecology or urology for a medical workup. As I'm not formally trained in sex therapy and don't do this type of intervention, and there are a few providers of this nature in our community, I've resorted to referring my patients to online resources. Not being trained in this area, is there something more I should be doing? This is a small part of my practice, but it does come up. Do either of you have some thoughts about that?
Jenny, I'll just say real quickly that I just think it should always be asked if there is anyone that they would like to talk to about it, because it might not be that person, but they can refer them out, or they can make sure that someone's there to talk to them. They can get an idea. It doesn't have to be a long conversation, but just finding that out, I think, is smart.
I think the most important thing is making sure that a patient of any age has as many resources as possible. And certainly, that's what we've tried to do in Will to Love with our male and female self-help programs, is create online tools that are available 24/7 that really kind of go over everything in a box, from all types of cancer treatments and their side effects to how to prevent or overcome problems to sexual communication and relationship issues. But that said, not every patient has the reading level or motivation to go through a self-help program by themselves. And one of the things we've added to Will to Love is is actually a pro portal for healthcare professionals that includes some online training and a clinician's manual on using our self-help programs with patients. And with an adolescent, that might be very helpful as a resource, because we really don't want young people under 18 to purchase subscriptions on our website because of legal issues, but that doesn't mean that a 16 or 17-year-old couldn't make very good use of some of those tools, but with the guidance of a clinician, and that's kind of a way of doing that.
I mean, I'll just add my 2 cents here. I mean, it sounds like you're doing a lot of things that are really important, and you're certainly really thoughtful and thinking about what you should be doing. I mean, as a psychologist, you know, I guess from a developmental standpoint, and I'm someone who's worked almost exclusively with adults, but I'm just thinking about my experience in developmental psychology. I mean, it seems to me that, you know, just talking to them about their feelings about the, you know, on the developmental side and how they're coping is probably going to be what they need more than an actual sex therapist. I just think that it's really all about, like, does it influence their social life? You know, can they do these kinds of things? To me, you know, what about dating? They're starting to date, you know, those kinds of things. I think you're probably doing all of those things, you know, as a psychologist, or, you know, and if you can't, you know, probably referring them to someone who, you know, who has, you know, maybe worked with, you know, that population around these issues in particular. But I would be surprised if many truly needed to talk to an actual sex therapist about those issues. And, you know, I don't know what your reaction is there.
Yeah, maybe if they had a really severe physiological change like an ostomy or a limb amputation or something like that, something that made sex technically difficult, they might need some specialized care. But I think you're right that the most important issues are feeling attractive and starting new relationships and using contraception properly and all those good things that we'd like our teens to do. Well, you know, I'm aware that we're kind of at the end of our time now. In fact, we've gone just a few minutes over, and I think this has been just a really terrific experience, and I hope all of you in the audience have enjoyed it as much as we have, and look forward to our next webinar, which is going to be, I believe, August the 16th, the Sometimes Off the Beaten Path to Parenthood After Cancer. So we hope you'll all join us again, and thank you again, Jenny and Erin.
Of course. Thank you for having us. Good night.
Good night.
Bye.